Okay, guys, this is a three-part lecture series on chest and vascular. The first two lectures are chest lectures, and the third lecture is primarily a vascular lecture. Just like other modules, three basic question types. So here's our first case. We've got a lateral chest x-ray, and we're seeing this is an Ant Mini. There is a donut appearance of the hilum. So yes, that could be lymphoma, but it's usually when they show that particular sign, that's a sarcoid sign. All it really is showing is that there's bulky hilar adenopathy. See, here's a follow-up question. What's that thing? What's the hole in the middle of the donut? It's the same thing as you see here on a normal lateral chest radiograph. This is the so-called black hole, and it's the left upper lobe bronchus en face. The left pulmonary artery is going to go over top of that thing, and then immediately anterior to that is going to be your right pulmonary artery. So, right, left. Okay, so let's do some vocabulary. Chest has got a few vocabulary words, and because of that, they lend themselves very easily to multiple choice. And even though it might seem basic, this is the kind of stuff that you forget or overlook as you're studying. So what's the difference between a mass and a nodule? You probably remember that there is a size difference. If I was going to write a multiple choice question about this, your choices would be 1, 2, 3, 4, 5, and then I would mess with you and I would change the units. So some of them would be centimeters, some of them would be millimeters, some of them would be inches. The answer is 3 centimeters. So 3 centimeters and bigger is a mass, 3 centimeters and smaller is a nodule. So what's the difference between consolidative and ground glass? Like, what is the actual difference? I know that they look different, and I'm certain that you could point them out different, but if you were asked to define them, how would you tell the difference? Well, both of them are filling processes. You've got stuff filling the alveoli, fluid, pus, hemorrhage, etc. The difference is that with consolidation, there's more of it than there is with ground glass. And the definition is that the vessel that runs through there is obscured because it's dense enough to obscure it on consolidation. And on ground glass, you can still see the vessel through there. So let's do some localization. This is how you had to read chest x-rays if you trained in the Cretaceous period and CT wasn't an option. It seems silly now to try to localize things off a chest x-ray, just as silly as it is to try and diagnose congenital heart disease off a chest x-ray, but yet it's still a highly testable topic. So here's a mass, but what the question is, where is it? So how would we localize this particular finding? And this is a sign. So we can see that it's extending above the clavicles, and this is helpful. So this is something that is in the posterior mediastinum. So things that extend above the clavicles are said to be both retrotracheal and posterior, because the anterior mediastinum stops prior to that. Posterior mediastinum will extend above the level of the clavicle. Here would be a companion case where we see there's a mass that is stopping right at the clavicle. And this is how we would know. It's using the same sign but in the opposite direction to know that this is an anterior located mass. So what about that thing there? This is a a mass, probably, that is extending below the dome of the diaphragm. So we're using the diaphragm there as a marker. And this supposedly means that it is more likely to be posterior. So if you've got a mass here that is anterior, you can see that the way that the diaphragm works, that it will sit more on top of it. But as we go further back, a pulmonary mass that's still in the lung would look like it's underneath of the diaphragm, being more posterior. Bottom line, the posterior costophrenic sulcus extends more caudally than the anterior basilar lung. So there you go. So we've got a chest x-ray here. Patient's got pretty bad emphysema. We zoom up on the hilum there. We can see that there is a mass, but we can also see the vessels clearly through that mass. We can see, okay, so mass here, right? But then you see a vessel running right through that. You can see here also a mass, right? Vessel. So we can make out both of these things as separate. So Ben Felsen, the father of chest radiology, who was a huge badass, by the way, described this thing called the silhouette sign. Basically, if you have two things that are different densities sitting right next to each other, you will be able to tell them apart. You'll see that there'll be a border, there'll be a line there. But if they're the same density and they're sitting right next to each other, it'll look like they blend in together. So for example, if you have a mass that's at the same level and the same soft tissue density at the hilum, it will obscure the border of the vessels. But if you have a mass that's either in front of or behind it, you won't be able to see, or you will be able to see a strict delineation. And this is the so-called hilum overlay sign. So if you have a mass that is either anterior or posterior to the hilar vessels, you'll be able to see the hilar vessels through the mass. If it's at the level of the hilum, you won't see the vessels. They'll blend in together like the two orange circles on my diagram. So we have another mass, zoom up here, and the point of this is to show you that the border tends to fade out as it becomes more peripheral. So allegedly, the reason that this happens is it's based on the curved nature of the chest, and as you fire your x-rays through the chest, you get a sharp border where you're going through lung, but then when you're not, you've got this tangential relationship that, or a lack of tangential relationship, that causes to blend into the chest wall. So the shadow becomes more ill-defined. Something like that. Or you can just remember it as the incomplete border sign, which basically means that you're dealing with an extrapleural or an extrapulmonary finding. That's something that's along the pleura. Incomplete border. Here's another example. See a clean border here, but then it sort of fades out into oblivion, and it's another extrapulmonary pleural-based finding. So let's compare and contrast these two cases. Both of them have air around the heart, but the orange case, the air appears to be stuck sort of underneath of the great vessels. And this is pneumopericardium versus a pneumomediastinum. Now, you see pneumomediastinum a lot more often, right? This is the one you see all the time, bad traumas or whatever. So you can, I mean, at least for me, I've sometimes the first place that I notice it is the subacute gas in the neck, and then I look down into the mediastinum and I'm like, oh yeah, okay, there's gas there too. So you can remember that the pneumomediastinum extends everywhere. It makes it easier to remember that the other one is the other one. So there are three basic patterns of pulmonary nodules that are described, and they have a differential. Now, as I've talked about in my books, it's difficult to write a multiple choice test question based off a differential case, but you can, and the way that you can do it is you can say stuff like, which of the following is not in the differential, which of the following would not be a random nodule, or which of the following would not be a paralymphatic nodule. Or you could just ask, what pattern of nodules is this? And that way you would have to be able to differentiate between them. So let's do that first. So random nodules will involve the pleura, but they will not be as evenly spaced, and they will not clearly be involving a perilymphatic, peribronchovascular distribution, as opposed to this here, where you can clearly see the nodules are along this peribronchovascular pathway, and they're involving the pleura. And then lastly, we've got a central lobular case. These are the easiest ones to tell because that's the one that spares the pleura. Like this guy right here. You can't let that go. Okay, so what are the random nodules? The way to think about these are things that are spreading hematogenously. It's not following the strict lymphatic drainage. It's just sort of everywhere, all the way out to the pleura. So hematogenous Mets, TB, fungal infections. Now, perilymphatic has the classic one. If you were going to pick one or only remember one, it would be sarcoid. Silicosis is the one that confuses a lot of people because they think that, well, you're breathing in silica, it should be a centrilobular finding, and it is also. But it's also moved around through the lymphatic system as well, and that would be the trickiest one. And if I was writing a multiple choice test, that would be the one that I would pick, is to see if you knew that silicosis is in the perilymphatic differential, because most people would think it would be centrilobular, and it is. It's in both. So you'd have to be creative in what you used as your distractors. But and then instead of being hematogenous, this is lymphatic spread, so like a lymphatic spread of malignancy, and that's easy to remember because lymphatic is in the name, perilymphatic. And then lastly, we have centrilobular, and these are pretty easy to remember. Just think about stuff that's inhaled, like it's at the end of the bronchus, right dead end in the middle. So hypersensitivity, this is classically ground glass, smoking-related stuff, RBILD, or endobronchial spread of infection. Chest radiologists love atelectasis, and they also love named signs. So when you combine those two things, then you've got a high-yield topic. So the orange one here, let's take a zoom in. We can see that there is the so-called Luftsickle or air sickle. Luft means air in German. And what you basically have is this lucency along the mediastinum from interposed left lower lobe apex, the superior portion of the left lower lobe, that's smashed between the mediastinum and this collapsed left upper lobe. And then the yellow case is the so-called flat waist sign, where you get this triangular-shaped retrocardiac opacity that looks like a hill or something, or just a triangle. That's the so-called flat waist sign. All right, let's compare two interstitial lung diseases, and these are the two most common ones. So on the orange case, we've got so just a few gamesmanship things with regard to this. If they are showing you either an axial, it's even better, and a sagittal plane. If they're showing you interstitial lung disease in a sagittal plane, they are trying to show you that there either is or there is not an apical to basal gradient. In other words, it's getting progressively worse as it goes down. And there are certain pathologies, and you need to memorize which ones, that have a upper lobe predominance or a lower lobe predominance, because that lends itself well to multiple choice as well. But classically, UIP gets worse in the lung bases. So you can see that even though there is some honeycombing, which is a buzzword, in the upper lobes, that there's more of it in the lung bases. The other reason to show a sagittal CT image in a thoracic case is to show you that if there is sparing of the costophrenic angles, because there are certain things that do that, like LCH. You can show sparing of the costophrenic angles in an axial plane. I just think that's way harder. Most people would show it in sagittal. So the way to keep these guys straight basically is buzzwords. Honeycombing is UIP. Traction bronchiectasis is UIP. Now, the things you need to know about UIP in addition to that are, well, let's back up. Honeycombing is, some people get down in the mud and say, is it honeycombing or is it paraseptal emphysema? Multiple rows are going to be honeycombing. Single row is going to be paraseptal emphysema. 2 or 3 hanging around. If they want to show you paraseptal emphysema, it's going to be 1 row. If they're going to show you honeycombing, it's going to be probably 3. They want to be clear about that. UIP is bad. It's basically like having lung cancer. It has a very terrible prognosis. It does not respond to steroids. A lot of interstitial lung disease does respond to steroids, and there are people that will argue that the way to read interstitial lung CT is basically to say, it's UIP, it's not UIP, or I don't know if it's UIP or not. And that helps guide whether or not they need biopsy or not, because it's really the main thing that pulmonologists care about is this going to respond to steroids or not? So UIP is the most common. It's got the crappiest prognosis. Its buzzwords are honeycombing and traction bronchiectasis, and like I mentioned earlier, it has a classic apical to basal gradient, and to prove that, they're going to show it on either coronal or sagittal. Or I guess they could show multiple sequences of axial, but I would think if they were going to show a single picture that it would be sagittal. NSIP, ground glass. Just remember, ground glass with subpleural sparing. So see how this is, there's like an area that's spared, like right here. That's what I mean by subpleural sparing. And the rest of it is this sort of homogeneous ground glass opacity. And another thing that's very important to know is this. This is the scleroderma case. This is how they love to show this. Dilated esophagus with this faint ground glass sort of looking stuff. If you see a dilated esophagus and they want to know about ILD, doesn't even matter if you can even see the lungs or not, you know it's NSIP. Is there an association between scleroderma and UIP? Of course there is. But for the purpose of multiple choice, it's NSIP because they're slightly more common. When you're doing multiple choice, a lot of times you have to deal in absolutes. In the real world, that's the art of medicine, is that absolutes are often out the window. But for multiple choice, think more in absolutes, especially with chest. Okay, so we've got 3 axial cuts demonstrating primarily a hilar central pattern of ground glass opacity. It's worse on the left than the right. But when you're looking at ground glass cases, look for the distribution and notice that it's more central, like this. That sometimes is helpful. So this is really vague, right? This could be lots of stuff. This could be pulmonary edema. Maybe it could be ARDS. It could be lots of different stuff. Lots and lots and lots of different stuff. Without any history, it's very difficult. Infectious processes can look like this. But for multiple choice, they're going to have to give you a hint. Something like that. So here's your classic hint. If you see nipple rings on a chest x-ray, everyone knows that means that this person has HIV. Because everyone with nipple rings has HIV. Every guy with nipple rings has HIV. And probably 80% of girls with nipple rings also have HIV. Or at least they have bad breath. In my experience, nipple rings and bad breath go together. So what do you need to know about PCP? Basically, it's perihilar, it's ground glass. There can be cysts. That's in a minority of cases. It's more likely to be shown with ground glass. It's nice that because ground glass is so nonspecific on chest CT, history is going to be critical. They're going to have to either tell you he has AIDS or they are going to have to show you nipple rings and make you infer it. Here's another case. Zoom in, give you a hint. I'll either have to tell you. So this is one where they wouldn't have to tell you. This is an Aunt Minnie. They would not have to tell you that the guy has AIDS. I'm being nice and telling you. Whereas, contradistinction to the PCP case, where you have ground glass, which can basically be anything, this is a more Aunt Minnie type appearance. So this is the perihilar flame-shaped opacities. This is Kaposi's. So let's blitz through some nuclear correlations to these two cases. So gallium versus thallium is a really good this versus that. They sound similar. People get them confused. So here's our Kaposi's case. Gallium cold, thallium hot. As opposed to our PCP case, which is thallium cold, gallium hot. Now the other way that this is typically used, thallium anyway, is our ring-enhancing brain lesion, toxo versus lymphoma, where toxo is going to be cold and lymphoma is going to be hot. Or in a setting of radiation necrosis versus tumor recurrence, where tumor is hot, radiation is cold. Now, usually people have a really hard time understanding that and keeping that straight, and they just try to memorize it and they get confused. I'm going to explain to you the mechanism, and then we're going to go back and look at those same cases, and it's going to be way easier and you're going to understand it perfect. So the way stuff works in nuclear medicine is you have an agent that mimics normal physiology. And it's easier to understand how it works, and that is the way that it works. The other thing that you need to know for the purpose of multiple choice is some trivia on where the energy comes from and what the photon peaks are, because it's just so easy to ask that. So thallium is produced in a cyclotron. It delays by electron capture. It's the T in GIT, which is the way to remember what the delays or decays by electron capture. GIT, gallium, indium, thallium. These also have around the same half-life, which is around 3 days. Thallium is 73 hours. It's a low energy, and that makes it unique. Pretty much everything else that you care about in nuclear medicine has either medium or high energy. Thallium has a low energy. And the characteristic X-rays are actually from a daughter product, which is mercury-201. So your peaks are 69 and 81. If you were going to only remember one, I would remember 81 because it's the major peak. Now, here's what's going to make this practically useful, is understanding the mechanism. Now, you may remember from med school physiology that there's this thing called a sodium-potassium pump, and that it's an active transport. And so, in other words, you've got a cell that's alive, a living cell, active transport. It needs ATP to work. You're shuttling potassium in, sodium out, and you're using up ATP to make that happen. Let's talk about gallium for a second. You may remember that gallium, as opposed to being an analog of potassium, which is what thallium is, gallium is an analog of iron. So the body handles gallium, which is +3, the same way it handles +3 iron. The physiology is basically that iron bound to lactoferrin gets concentrated in areas of inflammation, infection, rapid cell division. Therefore, it's a very nonspecific way to look for infection or tumor. Back in the Cretaceous period, this was the gold standard for cancer staging. Now we have a thing called FDG-PET. But I should point out that gallium can also bind to neutrophil membranes even after the cells are dead, which gives it some advantage over indium for white blood cell imaging, especially in a setting of chronic inflammation. So the take-home is gallium is iron, basically, and it's nonspecific inflammation, infection, rapid cell division marker. Just like with thallium, it's important to know the peaks, and there are 4 with gallium. The way that I remember this is 100, 200, 300, 400. I think that if you've got a really excellent memory and you can remember these things as separate, then go for it. If you're in a hurry or you just got to memorize what you can, 100, 200, 300, 400. So gallium is the poor man's bone scan. You have uptake in both the cortex, like a regular bone scan, and also uptake within the bone marrow. Now, because it's the poor man's bone scan, degenerative changes, fractures, growth plates, all that stuff's going to be hot, just like in a regular bone scan. The liver, which is going to have the highest uptake with gallium, is one of the ways that I'm like, that's gallium. Hot liver, looks like a faint bone scan, gallium. What about kidneys? Is that okay? Sorta, but let's just say no. If you've got renal uptake after 24 hours, that's bad. Remember that gallium is like this nonspecific inflammation marker. So inflammation in the kidneys is abnormal. Now, what about breasts? Is that okay? Yes, if it is symmetric and faint. If you've got asymmetric breast uptake, that's pretty much always abnormal. You can think about things like mastitis, you can think about things like tumor. And of course, lacrimal glands are always seen, or also seen with gallium. This is panda sign, sarcoid, Sjogren's, HIV, Sjogren's. Okay, so gallium versus thallium. Now, this is a Kaposi's case, right? Flame shape. Kaposi's is a tumor, so it's alive, so you would expect that thallium would be hot. And because it's sort of a really low-grade smolder, it's not triggering a lot of inflammation. That's why gallium is cold. Or you can just remember that if one's hot, the other one's cold for the purpose of multiple choice. So what about PCP? This is like an infection, right? It's not a tumor. It doesn't have a sodium-potassium pump. It's using ATPs, active transport. But it is an infection, so you've got smoldering inflammation. So thallium cold, gallium hot. Now, for thallium here, if it's a tumor like lymphoma, for sure it's going to be hot, right? And toxo is not a tumor and does not have a sodium-potassium pump. It's working with active transport, so it's going to be cold. And then tumor recurrence versus radiation necrosis. Tumor is alive. Tumor has a sodium-potassium pump, so it's going to be thallium hot, and radiation necrosis is not. Okay, so moving on. This is another classic this versus that show in chest. This is your halo sign where you've got ground glass peripherally. This stuff. Notice you can see the vessels through it, right? That's what defines ground glass. And then this central consolidative part. It's your halo. And then the opposite is where you've got this peripheral consolidative process here around ground glass and the center. And that's your reverse halo or your atoll sign. So if you're going to remember one thing about each, this is what I would remember. Invasive fungal, where you've got the fungus there in the middle and it's like growing out and causing little bits of microhemorrhage. That's your ground glass haloing around it. Versus COP, where it's just this smoldering sort of quasi-pneumonia thing going on. Or you could remember that sort of looks like a C. But it could be all the way around. In which case it would look like an O. COP. Okay, so the purpose of this test question is to show you that you've got upper lobe process on the orange and a lower lobe process on the yellow. And I mentioned before that this makes for really excellent multiple choice. And the way that this can be written is, which of the following is upper lobe predominant out of these four choices? Which of the following is not upper lobe predominant out of these four choices, or lower lobe? You have to have, this is one of those lists that you have to memorize. So upper lobe predominant, CF, supposedly you've got cilia causing some, it's beating the junk out of the bottom parts of the lungs, but it's sort of stagnant at the top. That's why CF has an upper lobe predominant. Anything that's inhaled, remember that you've got greater ventilation up top and greater blood flow down below. So all the inhaled stuff. The exception, remember, exceptions are highly testable. Asbestosis is the exception, and the way to remember that is that the little pointy fibers shoot all the way down to the bottom parts of the lung like they're being fired out of a nail gun, all the way down to the bottom part of the lung. That's how you remember that. RBILD, which is smoking, so anything that's ventilation dependent is going to be upper lobe predominant. Primary lung cancers for the same reason. Smoke tends to affect the upper lobes more, so you're going to have more carcinogenesis occurring there. Angstbahn, don't have a good way to remember that. You just have to know that it's upper lobe predominant. Maybe you could say, in a chest x-ray, the part of the spine that I can see the best is sometimes the cervical spine, at least on the frontal view, and spine, ankspon, I don't know, or A's at the top, A's at the top of the alphabet, ankspon. Sarcoid, upper lobe predominant. I just remember seeing a lot of end-stage fibrosis cases with sarcoid that were much worse in the upper lobes. Now, lower lobe predominant, primary ciliary dyskinesia. Don't call it Cartagener's unless there's the heart's on the wrong side of the body. Remember, you don't always have to have that with primary ciliary dyskinesia. It's only maybe 50%, 40% of cases that actually have that. Asbestosis, which I mentioned before, firing down into the bottom parts of the lung. Hematogenous Mets, because more blood flow to the bottom parts of the lung, more ventilation to the top parts of the lung. Remember, Mets tend to be different sizes, round, and lower lobe predominant. And then RA, I remember that because it's the opposite of ankspon, so A comes before R in the alphabet, so A's on top, R's on the bottom. And then UIP, I mentioned that before, has a known described basilar predominance. So this is an Ant Mini. It's another case that's demonstrating your upper lobe predominant findings. A lot of times people will try to get you to call this cancer or to biopsy it. This is a classic look. Clearly has silicosis. Look at those lymph nodes. Angel wing pattern, buzzword. Calcified conglomerate of masses, upper lobe predominant, sort of stretching from the apexes down into the hilum. PMF. It's going to be dark on, if they could show you MR, it's going to be dark because it's fibrosis. T1 and T2 dark. So another really classic this versus that is cystic lung disease, where you have LAM, which has these thin-walled, all the cysts are about the same size, no nodules, versus LCH, the buzzword for these cysts is bizarre, and they have nodules associated with them. The way that I keep that straight is LAM is an estrogen-dependent process. It's going to affect the whole lung sort of homogeneously. That's why all these cysts are the same size. You only see it in women or girly men. Tubular sclerosis is the syndromic association. They could show you an AML and then show you lungs. LCH is smoking related. So it's going to affect things in a more heterogeneous pattern. That's why you end up with your bizarre shaped cysts. It tends to spare the costophrenic angles. The way I remember that is smoking is an upper lobe predominant thing, and therefore it's sparing the costophrenic angles. We just sort of have to remember that. And this is how they show sparing of the costophrenic angles. Sagittal, right? It's the easiest way to show that. Yes, it can be shown in an axial, but that would be really, really tricky. And the other thing to remember about it is that it's cyst and nodules. Smokers get nodules, right? So if you remember the smoking, you can sort of put it all together. So here's a really classic case also. This is your post-pneumonectomy case. And I show this, if you're going to get a post-pneumonectomy case, it's either going to, well, it's almost always going to be, you only really need to know one diagnosis, which is the bronchial stump leak. Now, how do you know that that's what's going on here? Well, probably if they just tell you that it's post-pneumonectomy, you can remember that I told you that there's only one diagnosis for multiple choice, and that's it. Or you can try to remember that after you've had a pneumonectomy, the space will fill up with fluid. Your body will fill that in with fluid. If it's not filling up with fluid, but instead filling up with air, so in other words, you're going from, it looks like there's a decrease in fluid, that is a leak. So we can see that we had this much lung, and now we've got more. That's more air. More air means there's air leaking. Should be more fluid. So here's a cardiac case, and it's listed as a this versus that. There is the finding, which is this subendocardial fat, which you probably know is seen in the setting of a prior MI. The reason it's a this versus that is that I want you to tell me what is the vascular distribution. What vessel had the MI? And the answer is that this is classic LAD distribution. So here you go. This could be shown for nukes. It could be shown in a case just like that where you've got subendocardial fat distribution, and they can ask you what vessel was hit. So remember, LAD, RCA is the rest of the septum and the bottom part of the heart, and then circumflex is circumflexing around the side of the heart. There's another cardiac case. This is your classic. It's just got all the findings. So left atrial enlargement. 3 main findings you need to know. Can be shown 3 main ways. The one is you can show this double density sign here. You may say, hey, that's the right side of the heart, but that left atrium is the reason you're getting a double density like that. The other thing is splaying of the carina. That's a classic left atrial enlargement thing. And then lastly, and this is the one that they'll show on the lateral view, which is the heart goes too far back. It should not go that far back. It should stop before the spinous process, so that's way too far back. And also, if you look close, you can see that there's been a mitral annular repair. So speaking of valves, this is another thing that makes for great multiple choice, is which is which. What valve is that? A, B, C, or D, right? So you need to know this. So let's go through them. Red is right square dead in the middle, and when I start, I always start in the middle, and when I start my alphabet, I start with the letter A. Orange is the next color, and you're going to, I mean, it's on that side, and if you can, I mean, you see this is the one you see the most, which is the mitral. The most superior one is blue, and it's sometimes asked like that. What is the most superior valve? And this is pulmonic. And then lastly, what is the most inferior? And that's tricuspid. So try to remember that tricuspid is the most inferior. And the way that I sometimes will remember the tricuspid is if they have a pacemaker here and they show the lead, and the lead goes through that tricuspid valve. That is a way to prove that that is the tricuspid. And also, it's sort of, if you can remember the course of the pacemaker lead, that helps me remember where that tricuspid is. Remember, pulmonic on top, tricuspid on the bottom, PT, physical therapy, PT, pulmonic on top, physical therapy, PT, pulmonic on top, tricuspid on the bottom, aorta in the middle. Start with the alphabet. A's the first thing you say, and then mitral is the other one that you see all the time, and that's where it's at. So this is the end of the first part of the talk. Part 2 will be more thoracic processes, and then part 3 is going to be primarily vascular.